All right, let's go ahead and get started. Welcome, everybody. Thank you for joining us today. I am Dr. Jeff Katzman, the Director of Education at Silver Hill Hospital. Excuse me. We're absolutely delighted to have you join us and are privileged to welcome Dr. Snehal Bhatt, who will be presenting on the topic of substance use disorders with a focus on the current understandings, efficacy, and risks of cannabis. And I have the great pleasure of introducing Dr. Bott in just a moment. First, as always, a little bit of housekeeping. Our next grand rounds take place on March 26th with Dr. Alan Barsky, who will talk to us on the topic of collaborative care, conflict management with patients, families, and professional colleagues. To see all of our Silver Hill Share events, you can visit silverhillhospital.org/calendar, and they're all listed there. We have many ongoing virtual series that may be of interest, so take a look. And back to today's lecture. Your questions really are an important part of our grand rounds, and I will moderate a Q&A discussion with Dr. Bott at the end of his lecture today. It's a great opportunity to put forward questions and comments to Dr. Bott, which you can submit anytime during the lecture by using the Q&A link. And I think there may be many questions, and we will try to get to as many as we can. If you'd like CME or CEU credits for today, please complete the evaluation survey that will automatically show in your browser when we end the webinar. We will also email a copy of the survey to today's participants. And so that all participants have enough time to complete the survey, it will remain open to the end of the day on Friday, and certificates will then be emailed all at once within a week. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. And Dr. Bott will also show a slide with his disclosures. It is now really my great pleasure and an honor to introduce our guest speaker today, Dr. Snehal Bhatt. And Dr. Bhatt received his BA in psychology from the College of New Jersey in 2001, followed by his MD from the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School in 2005. He subsequently completed his four-year residency in general psychiatry at Robert Wood Johnson Medical School in 2009, and then came to the University of New Mexico to complete an additional 1 year of training in addiction psychiatry, finishing in 2010. That's when I first had the honor of meeting Dr. Bott, and he has been really an esteemed colleague of mine and dear friend now for many, many years, and is really the first person I think of when I have a question about addiction psychiatry specifically and just about taking care of patients generally. Dr. Bhatt is really a passionate provider and is passionate about providing equitable, state-of-the-art care to individuals with substance use disorders. Substance use disorders are treatable chronic illnesses that profoundly impact many individuals and their families and their communities. But unfortunately, these illnesses also remain highly stigmatized, and access to effective treatments can be a major challenge. Dr. Bott is motivated by the challenge of helping to create systems of care that are patient-centered, anti-stigma, equitable, and that offer cutting-edge treatments in a trauma-informed and integrated settings. Dr. Bott currently serves as the Chief of Addiction Psychiatry at the University of New Mexico and provides much of his clinical care at the UNMH Addiction and Substance Abuse Program, known as ASAP. Additionally, he's very engaged in clinical and implementational research that focuses on improving outcomes for patients with opioid use disorders and is currently involved in multiple NIDA-funded clinical trials, as well as multiple projects through the Project Echo platform. He's engaged in research that explores the therapeutic potential of psychedelics, and he was very recently funded to study cannabidiol for opioid use disorder through NIDA and among many other studies that he's been involved in. He's actively involved in 6 research projects, in fact. He enjoys teaching, is involved in clinical teaching of medical students, residents, and fellows, and I was charged for years with running the education programs at the University of New Mexico, and Dr. Bott was long considered among the very best teachers in the university. So with that, it is a real honor for me to get to bring Snehal to our Silver Hill Hospital Grand Rounds program today to guide us all in our learning. And Dr. Bhatt, the stage is yours. Thank you for joining us. So good to see you. And I'll be back when you're done, and we'll have a little chat, fueled by the questions that our audience puts in.
Sounds great. Thank you, Dr. Katzman, for such a generous introduction. And let the public know, right, that I consider you a great friend and also a mentor. I think I've learned over the years many things from you, and so it feels extra special and really feels like an honor to join this presentation today.
Thank you.
And I put together a lot of slides before I even put them up. And I was telling the group earlier, the planning group, that I felt a little bit self-conscious about it. But I think I figured out err on the side of making extra slides with lots of references. So and they're going to be shared. So anyone who is attending can have access to it because these are questions that probably come up in our clinical work daily, right?
Thank you.
Cannabis is in public discourse. People are talking about it. Political landscape, right, is also kind of mixed into that. And our patients are talking about it. So hopefully this serves for all the attendees as extra reference. I'm gonna be sure to end the presentation with 20 minutes roughly of question and answer time. And with that, let me pull up the presentation.
Great. I'll be back in a few.
Yes, sir. So I'm gonna, let's see. Okay. Let me put it on the slideshow mode. There. So yeah, I'm gonna talk really focusing on cannabis. And even as I start, let's see, in terms of disclosures, I do not have any relevant financial relationships to disclose in relation to this presentation. I will be discussing off-label pharmacotherapy. There are no FDA-approved medications for cannabis use disorder. So towards the end of the presentation, I will be speaking about pharmacotherapy. Something I did not include in the disclosure slide, but I did reflect a lot in preparation for this presentation. And I feel comfortable stating that I think I have quite a balanced view of cannabis. This is something I talk about with my patients on a near daily basis, right? I do my clinical work again in a setting that serves patients with substance use disorders and co-occurring psychiatric illnesses. So these questions are always coming up. And I think I have a fairly balanced view on it. And my goal today then is to present a balanced view to you all. Talking about both potential benefits of cannabis for various medical conditions, as well as the potential risks. And then finally, going a little bit into reviewing treatment options for individuals who may have cannabis use disorders. So that's everything I'll try to accomplish. Pretty big topic, right? So let's go through that. I'll start a little bit with kind of the history of cannabis, kind of some of the terminology that you might hear, along with neurobiology, before I jump into the clinical portion. So that's how I'll organize it. So a little bit of historical perspective, right? Perhaps quite well known that cannabis has been around for a long, long time. And the use dates back thousands of years. Some of the earliest texts that are out there you find in kind of ancient China. The first text you find was compiled around 100 CE, but it came from even earlier oral traditions. Interestingly, this is available on Amazon. For kind of a historical perspective, if someone's interested, you can actually get it and read it. There are two volumes of it. And the first volume of this book, this text, discuss kind of herbs that were considered medicinal, but without many toxicologic effects. And interestingly, that's where cannabis was included. By way of reference, ginger was included in the second volume, which includes herbs with potential therapeutic benefits, but also with potential side effects or toxicities. So sort of interesting. Also in ancient India, you actually find references to bhanga, which is a cannabis preparation in Atharvaved, which was compiled around 1000 BC, where it was sort of touted as a potential treatment for anxiety disorders, among other things. And in ancient India, also cannabis was used for its euphoric properties, along with as a sacrament. So the use goes back a long, long time. But here in the Western world, we don't really start seeing it until much later, right? As a result of colonization. Another historic relic here that I've put an image of that I think is available on the internet is by O'Shaughnessy, who was a British physician, army physician stationed in India. And he wrote this, really, it's a booklet. It's more of a booklet than a book, called On the Preparation of the Indian Hemp or Ganja, that kind of talks about, reviews the use of cannabis in the treatment of various medical conditions. And it was even in the US Pharmacopoeia from 1850 until 1942, right? Until it was kind of in the US criminalized in 1937 under the Marijuana Tax Act, which taxed and criminalized the use of cannabis or marijuana. But medical use remained technically legal, but discouraged because of other things like taxes, more regulations. And all that changed in 1970 with the Controlled Substances Act, which placed cannabis under Schedule 1, right? Which really means when we say Schedule 1, what does that mean? Legally, that means these are substances with high abuse liability and no therapeutic potential. And at the federal level, that's where cannabis remains 5 decades later, which creates this incredibly interesting and confusing and complicated landscape where there are all these states with medical cannabis laws, all these states with legal, cannabis recreational legalization. And yet at the federal level, it remains as a Schedule 1 substance. And I think that's led to a lot of sort of complicated discourse around cannabis. So that's where it is. In terms of terminology, people don't really know the exact origin of the term marijuana, but it likely originated in Mexico and really in the U.S. If you look at newspaper articles from before the year 1900, you hear the word cannabis. And then when you come into the 1900s, particularly 1920s, 1930s, all of a sudden you start hearing the word marijuana coming up more and more. And that's a whole other presentation that I won't go into, but cannabis really is the genus name. And cannabis sativa, cannabis indica are kind of the two main species that are found. There is also a third species called cannabis ruderalis, which is found, I believe, in Siberia and has a very low THC content. And I've never seen it. In 16 years of clinical practice as an addiction psychiatrist, I have not seen cannabis ruderalis, but certainly sativa, indica, and many hybrids abound in the markets. There is also the word hemp, which is legally defined as cannabis plant with THC content of less than 0.3%. Long history of its cultivation, mainly for seed and fiber. You might find hemp seeds right in your local health food store, or you might find clothing made of hemp. There are also hemp oils that people sell. And because its THC content is less than 3.3%, it doesn't have the same federal regulations as other cannabis does. So that's around. So just a little bit about terminology. I'll be using the word cannabis here in my presentation. Often when I talk to my patients, I ask them, right, I want to engage them in a discussion about any cannabis use that they may be using. And I ask them, well, tell me a little bit about cannabis use. And invariably, what I hear is I use cannabis sativa because it gives me energy, it gives me creativity, or I use indica because it gives me body relaxation. That's usually the first response I get. And when I'm working with residents or medical students or physician assistant student, which is nearly daily, one of my messages, and they know this by now, is that don't stop there. Sativa and indica in the year 2025 are a lot more relevant if you are a botanist. But if you are a clinician, if you're a physician, they don't tell us a whole lot, right? Because hybrids dominate the market, and also with all the cross-pollination and everything, there are more differences within sativas or within indicas than differences between those two groups. So I really want to go beyond asking about indica and sativa and starting to get at kind of the chemical profile of any cannabis one of my patients may be using. So that is something I will kind of really underline for the clinicians who may be in the audience. Gonna go a little bit into neurobiology. I'm not gonna spend too much time in it, again, because I want to get to, there are probably many people even in the audience who can talk about neurobiology more, eloquently or more intelligently than I can. But I also want to get to the meat of the presentation, which will be kind of reviewing some of the benefits, harms, and treatment approaches. So here, this is a picture some of you may recognize of Raphael Mechoulam, who, if there was like a Nobel Prize for cannabinoid research, I think he would be the first candidate for that prize, is Professor Mechoulam, um, who's played a role. He played a role in sort of isolating THC, among other things, cannabidiol, in identifying our endocannabinoids and highlighting the role of our endocannabinoid system. None of that would have happened without Dr. Mechoulam's work. So that's a picture of his as sort of just an honor and a recognition. And something he said, a quote that I really like, is there is barely a physiologic system in which endocannabinoids are not involved. Hence, its importance is far beyond that of THC and marijuana. And I like that because, again, in our public discourse, we hear about THC, we hear about cannabidiol, right? We hear about all these phytocannabinoids that come from the cannabis plants. We may even hear about synthetic cannabinoids, right? Things like spice, quote unquote, or K2, which have been misused, right? But if we're really talking about cannabinoids, if we really want to talk about cannabis, we at least have to start way upstream with our endocannabinoid system because it's so essential to multiple functions in life. In fact, cannabinoid receptors evolved over 600 million years ago, well before cannabis plant or humans, right? And they're found in every vertebrate studied to date. So cannabinoid receptors, they must play some essential function if we're gonna find them in every vertebrate, right? And they've been around for 600 million years. And our body actually makes endocannabinoids. Right? We don't find that, for example, with alcohol. Alcohol doesn't have its own dedicated receptor system and endo alcohols, right? Necessarily that play the same kind of role. We do have that with opioids, with our opioid receptors and endorphins, for example, but we don't have that with cocaine or methamphetamine or many of the other substances that people use. We do with cannabis. We have dedicated receptors, cannabinoid 1 receptors, which are largely found in our central nervous system, where they regulate a number of different physiologic processes, and cannabinoid 2 receptors, which are largely found in our peripheral nervous system, along with some of our immune system and also in the GI system, actually. And at least 2 endocannabinoids that our bodies make, right? They're endogenous to us humans. Endocannabinoids have been identified. Anandamide, named by Dr. Mechoulam, I believe. I really like that name because Ananda in Sanskrit and many other Indian languages roughly translates to joy or happiness. And that's, I think, what drove him to name it Anandamide or AEA. And there is 2AG. They're both endocannabinoids and they both have slightly different roles, which I'm not going into in this presentation, but they're both important. That's one thing I want to highlight here, right, for today. This is a classic image that many of you in the audience may have seen. Comes from a paper that was written by Velasco back in 2012. So this is about a 10, 12-year-old picture. And what this shows, I'm gonna see if I can put my pointer on a laser pointer. Yes, I can, right? So I'm gonna go back. So what this shows is this is the presynaptic neuron. This is our postsynaptic neuron. One of the things this highlights is that endocannabinoids, which are this AEA or 2AG here, these little green triangles, are produced actually in the postsynaptic cell. And they're kind of made on demand in response to a number of physiologic changes, right? So they're kind of made from precursor chemicals. They kind of travel upstream to the synapse and bind the cannabinoid 1 receptor here in the presynaptic neuron. And when they go in general, they tend to downregulate the production of a number of other neurotransmitters, right? Which are these NTs, these round things here. So they down-regulate. That's why it says this negative, right? And then once the concentrations of the neurotransmitters have decreased, then our body responds. This enzyme called FAH or FA, which then starts breaking down our endocannabinoids. That's what's responsible for inactivating them, and they're gradually inactivated as this new physiologic balance is reached. So that's in a very basic way. This is what our endocannabinoids do. But things are a lot more complicated. And in the even in the 5 years after this paper came out, we just had an explosion of learning, right, about endocannabinoid systems. So this is a paper that came out in 2015 that I've also cited by Di Marzo, and you can see just how much more complicated the picture gets, right? Again, I'm not gonna go over this image because that will take about 20 minutes to really go over it. But what I really want to highlight, even without going into each individual component, this seems complex, right? This is our endocannabinoid system. It's a finely tuned system. So what happens when we start introducing exogenous cannabinoids to this finely tuned system? We know that it impacts our endocannabinoid system, often in very complex manners. So, for example, we have cannabidiol or CBD here. So this it inhibits FAH, which leads to less breakdown of our endocannabinoid system. So just simply introducing cannabidiol is going to modulate our endocannabinoid system, just as an example. And this can happen, right, in different ways, sometimes in fairly unpredictable ways. And I think this is where, as a clinician, one of my concerns or one of my concerns about people using exogenous cannabinoids, especially high potency cannabinoids, comes in. That is this going to interfere with this endocannabinoid system that has evolved over millions and millions of years and serves important physiological roles, right? So I've used the word exogenous cannabinoids, so it's only appropriate that I at least introduce it. Exogenous cannabinoids, right? Are things that come from, you can also call them phytocannabinoids, come from plants, mainly from the cannabis plants, at least 100 cannabinoids. And cannabinoids here means that they bind to and activate or somehow modulate our cannabinoid or CB receptors, right? The two that we hear the most about are THC, which is delta 9 tetrahydrocannabinol, and cannabidiol, which is often referred to as CBD, but there are many, many others, right? There's CBG, there's CBN, there are many others. And then there are also synthetic cannabinoids, which I'm not going into in this presentation. And then terpenoids are also found in the cannabis plant, and those are organic aromatic compounds that give cannabis its characteristic smells. And depending on the terpenoid content, the smell of the cannabis flower can also change. I'm gonna just quickly glance at the time. We're doing okay. So again, introducing delta 9 THC, the main point I want to make is that this is sort of the major psychoactive ingredient in cannabis, right, in the plant. And it's a partial agonist at both cannabinoid 1 and cannabinoid 2 receptors, but most of its psychoactive properties come through the cannabinoid 1 activation, right? And for something that's been used for so long, you can see that it was not purified until the 1960s, right? And our endocannabinoid system didn't really fully get elucidated until even more recently. So we haven't known a whole lot about a plant that we've been using as humans for many, many, many years. Cannabidiol, much more complex. It's I think acts as a negative kind of an allostatic modulator of the cannabinoid receptors. So it does a lot of things. In general, very little affinity for cannabinoid receptors, quite a bit less than THC. And again, it can sort of change our endocannabinoids. It can also counteract in many of the studies some of the effects, some of the adverse effects of THC. It may also have neuroprotective, anti-inflammatory properties. And a lot of medical cannabis research has started looking at cannabidiol because of its potential therapeutic value and also because of its relatively lower chance of leading to side effects or adverse effects compared to THC. So with that, I'm gonna go into remember the second part of my objective was reviewing the potential benefits. And if you remember one of my early slides from ancient India, from ancient China, it was used for everything, right? From anxiety to headaches to malaria, to sexually transmitted infections to constipation. I mean, it was used for everything. And I feel like, several hundred years later, we've kind of come back to that, where people are reporting it works for everything, right? I think here in New Mexico, I think there's 20 or 30 different qualifying conditions for which medical cannabis can be certified. But what does the research tell us, right? Putting aside kind of the claims and putting aside sort of the medical cannabis laws in various states, where is the state of evidence? That's what I want to focus on, because that's ultimately, as a clinician, that's what I'm looking at to start things off. So first, the highest level of evidence is current prescription forms. So in the US, we have dronabinol or marinol, which has been around for a long, long time. That's a synthetic THC. And that is, in fact, approved for chemotherapy-induced nausea and vomiting, along with appetite stimulation in things like HIV-related wasting. Right? That's where it's been approved and has been for many years. There is also Nabilon, which is also a synthetic THC analog. So it's a little bit different than dronabinol, but pretty similar. And that's also been approved for chemotherapy-induced nausea and vomiting. And finally, most recently, cannabidiol in a pharmaceutical form, which has been associated or which has been approved by the FDA for some of the severe kind of what have been termed catastrophic pediatric epilepsies, right? Which are epilepsy seizures related to tuberous sclerosis complex, seizures related to Dravet syndrome, seizures related to Lennox-Gastaut syndrome, and it is approved for that. And then there's this very interesting medicine called nabiximols, which is not approved in the US, but it is approved in Canada and many European countries, which is an oral mucosal spray with a 1-to-1 concentration of THC and cannabidiol. And that's been approved actually for, among other things, multiple sclerosis related spasticity. That's it. These are the only indications right now that we have, right, for kind of cannabis products, cannabis related medications, with the most recent one coming for the cannabidiol in 2020. So the next level is maybe things that are not FDA approved, but still carry good evidence basis. So now let's go into that a little bit. And the most comprehensive document we have is now a few years old, but it still remains sort of a good place to start, which is this report that was put out by the National Academies of Sciences, Engineering, and Medicine. It was they got together and sort of and they reviewed all the evidence from the 21st century and put together this document. It's actually a worth reading, and it's public domain. You can download it from your favorite internet browser. And it really reviewed research since 2011, so relatively recent evidence. So these are the conditions for which that report says there is conclusive or substantial evidence of therapeutic effects. Only three conditions, right? Two of them, we already have some indications, right? One is antiemetics for the treatment of chemotherapy-induced nausea and vomiting. We already have FDA approvals for dronabinol, for Nabilon for that, for improving patient-reported multiple sclerosis spasticity. We already have an indication in Canada for that for nabiximols. One for which there is no indication, but according to this report, there is conclusive or substantial evidence is for the treatment of chronic pain in adults with cannabis. So that's one that gets added to the list. Then this report says there is moderate evidence for improving short-term sleep outcomes in individuals with a variety of conditions, including obstructive sleep apnea, fibromyalgia, chronic pain, multiple sclerosis. And then they say there is limited evidence, right? Kind of limited evidence of therapeutic effects for a number of other conditions, including increasing appetite, weight loss associated with HIV/AIDS, clinician measured multiple sclerosis spasticity. They added to it Tourette's, anxiety in kind of a public speaking context, and post-traumatic stress disorder, which was based on one single study. So if we look at conclusive or substantial evidence, this is it, according to the national academies. These are the only three conditions which fit the bill. And some of the other review papers, there are many of them out there, right? And I kind of focused on the big ones, kind of point to that. This was a great review that was published in the JAMA back in 2015. that again reported moderate quality evidence for chronic pain and MS-related spasticity. So again, similar to the National Academy's report, right? And I put in red some of the psychiatric things, right? Because I'm an addiction psychiatrist, so my eyes naturally go there first. So they said low quality evidence for sleep disorders for Tourette's, very low quality evidence for anxiety disorders, and they actually said lack of evidence for depression, psychosis, and also glaucoma, which comes up in public discourse quite a bit, right? Um, Interestingly, for pain, focusing on that, and I really focused on it because if you look at nationwide medical cannabis cards, by far, chronic pain is the number one indication why people receive medical cannabis cards, for which, again, there seems to be quite a bit of evidence. And in the Whiting study, in this review, overall odds ratio for 30% improvement in pain. Why 30%? That's actually a fairly commonly used parameter in chronic pain trials. You get about a 1.4 odds ratio. But with smoked THC, that odds ratio went up over three, almost 3.5, which I think is noteworthy. It seemed to work across pain conditions, but there were also more adverse effects, right? Including short-term adverse effects, serious adverse effects, and people actually were much more likely than placebo to stop cannabis because of adverse effects. With an odds ratio of almost three, they were almost three times more likely, which interestingly is about the same as the odds ratio for improvement. Um, this was kind of, again, some of the other major chronic pain studies. The study by Hill, which was also published in JAMA in 2015, said there was high quality evidence of cannabis for chronic pain and neuropathic pain. Some of the other trials were maybe less enthusiastic. Couple of studies I have highlighted from 2017, which weren't as enthusiastic, right? The Nugent study showed low strength evidence for neuropathic pain, insufficient for other pain. But I think more evidence than not, at least in my reading of the literature, does point toward, is consistent with what the National Academy said, is that cannabis can help adults with chronic pain, can also lead to side effects. And that's part of what we do as clinicians with our patients. This is a great review by Kevin Hill, that was published in the Green Journal not long ago. And great reading for any psychiatrists, psychologists, therapists out there who they do a very good job reviewing evidence. There is also another review by Black, and I've referenced all of this. I think 5 slides of references towards the end to help people find it if they so choose. So just kind of quickly reviewing the evidence for a variety of psychiatric conditions. The first one I looked at is depression. Lack of evidence. There are actually about 40 studies, including 22 randomized control trials. And when you look at them, there is lack of evidence supporting efficacy of cannabis when compared to placebo or active comparator. One thing of note is that none of these RCTs evaluated primary major depressive disorder. They all looked at depression in the context of another illness, right? Whether it's chronic pain. We know depression and chronic pain go hand in hand, right? There's a lot of literature on it, which I won't go into to retain my focus on this presentation. So that's the kind of things these studies looked at, but still found no benefits compared to a comparator. So good to know when we talk to our patients, right? When we look at cannabis and anxiety, the picture, I think, is more complex. According to this review from 2019, they reviewed 31 studies, including 17 randomized control trials. Again, a big caveat is that none of these evaluated primary anxiety disorders. They all looked at anxiety occurring in the context of another illness. For example, multiple sclerosis, right? But based on those studies, what conclusion they came to is that there is very low quality evidence that pharmaceutical THC, with or without cannabidiol, so it really seemed to be THC itself, leads to small improvement in symptoms of anxiety amongst those who have other medical conditions. So there may be something. But then I think the data gets more complex. If you look at epidemiological data through, some of these big bird's eye view epidemiologic studies, such as the NESARC, right? If you look at different waves of the NESARC, what you basically find is that people who are using cannabis or, at one point in time, several years later at another point in time are more likely maybe to have anxiety disorders. So I think the data is very mixed. And as a clinician, it doesn't give me very clear guidance. And ultimately, I'm going to do a very careful weighing of risks and benefits with my patients with an open mind, and an open ear, a listening ear to my patient as I elicit the pros and cons of cannabis use, or the anxiety with the patient. What about cannabis and PTSD? So nationwide, I said chronic pain is the number one indication for medical cannabis cards. It's a little bit different here in New Mexico, where I'm sitting right now, where the number one indication for medical cannabis card is and has been for as long as the medical cannabis program has been around, post-traumatic stress disorder. Again, a whole other topic, right? As to why that may be. So I focused a little bit on cannabis and PTSD. I think there is quite a bit of preclinical data that cannabis may in fact be helpful with post-traumatic stress disorder, as there is for many other psychiatric conditions. I think that data is there. There is a rationale that cannabis can actually lead to blockade of consolidation of aversive memories, fears, anxieties. So I think that's where that interest initially started. And that interest really gained steam or compounded with anecdotal reports, right? Of people saying, I have PTSD, I use cannabis, and my symptoms are better. And again, I don't want to discount anecdotal reports. I think one of my mentors here at UNM, um, uh, Dr. Uhlenhuth, said years ago when I was a very new faculty here that if you're not going to listen to your patients, who are you going to listen to? And that stayed with me, right? Like 15 years later. So I don't want to discount it, but I also want to bring in, right? As I'm eliciting the story of the patient's life, they're the experts in their lives. I'm listening to it with permission. I also want to bring in what we know from science, right? What we know from literature, from human studies. And there, the evidence is a lot more sparse. We don't have as much evidence, right? There are multiple retrospective chart reviews that generally show it's very interesting. I actually reviewed all of them in preparation for today. And they're very consistent, all these retrospective reviews showing some benefits of cannabis in sleep-related symptoms of PTSD, things like, sleep latency or quality of sleep or even nightmares. And some of the chart reviews also show improvements in global functioning. Very consistent, and none of them really show many benefits in other domains of PTSD, such as avoidance or intrusive thoughts or daytime symptoms. It really seems to be that sleep and maybe that's what our patients are picking up on. They're getting better quality sleep. There are only two randomized control trials. This one in 2015, which was a very small study with Canadian veterans. I believe the total number of people in that study was 10 or 20. It was a very small study that used Nabilone, again, one of our synthetic THC analogs. And what they found is that folks who received this, it was a crossover design, when they were receiving Nabilone, had reductions in recurring and distressing dreams, similar to those retrospective chart reviews. And they also just felt better and showed global improvement. So something, but again, a very small trial. A much bigger study done by Marcel Bon Miller in 2021, very good researcher, and they did this big study where they compared actually placebo to three different formulations of smoked cannabis, right? Which is important because our patients are often using smoked cannabis. They used a high THC preparation, a high cannabidiol preparation, and a preparation with kind of a 1-to-1 ratio of THC and cannabidiol. And what they basically found is that there was no separation of any of the active groups from placebo. They all improved, which we often see actually in substance use disorder trials, where people improve just from these non-specific interventions, right? Spending hours with the study clinicians and the research team talking about yourself, people listening to you, kind of fits in with Dr. Katzman's, the new program, right? About exploring the kind of the common themes, common elements of psychotherapy. We also see that in substance use research. So all groups improved, but there was no separation from placebo. So essentially, it was a, trial, negative trial, right? I guess in a technical sense. And that's where that research stopped. There is also this one study that I would be remiss if I didn't bring up. from 2015. It was a large chart review from the VA system that looked at veterans with PTSD, over 2,000 of them, who were admitted to specialized Veterans Administration treatment programs for veterans with PTSD. And the authors broke these folks up into four groups: people who never used cannabis, folks who used cannabis before treatment but then stopped, right? The stoppers, they called them. People you were using before and people who were using after, which they called continuing users, and people who did not use when they got admitted, but then picked up on cannabis use, right? Or starters, they called them. And then they analyzed all four of these groups. And what they found was that cannabis use here, again, in this large sample of veterans, was significantly associated with worse outcomes in PTSD symptom severity in terms of violent behavior and in terms of alcohol and drug use, right? So something there. And the folks who had the highest levels of violent behavior in particular were these new starters. You know, and starting cannabis really did seem to worsen PTSD symptoms, and stopping cannabis seemed to improve PTSD symptoms even when controlling for a number of covariates. So again, caveat, this is not a randomized controlled trial. This is a retrospective chart review, right? And that's a big caveat, but it still should be part of our consideration as we talk to our patients. And that's why I've included it. And there are a number of systematic reviews, and they all basically say the same thing, is that studies are of low quality, there is a medium to high risk of bias, and there is limited evidence, and they all tell us more high quality studies are needed. So we need to study this more, is what we hear from all these reviews. And when I was putting these slides together, these last couple of slides, a headline from one of these like popular magazines or online magazines, I think it was like Slate or Vice maybe, came to my mind, which said something to the effects of legal weed is everywhere unless you're a researcher, in which case good luck finding it, right? There's so many barriers to carrying out good quality research that it makes it hard. Uh, but we need that. We need good quality research. Cannabis and psychosis, not a lot of data. There is actually an active discourse going on that can cannabidiol in particular be helpful with psychotic symptoms, and there's maybe some indication, right? There is this one study from 2018 that showed cannabidiol led to an improvement in global functioning compared to placebo, right? And then also non-significant trend in some other trials towards cannabidiol improving some of the positive symptoms of psychosis. But those weren't really significant. And in the majority of the studies from my review, you don't really see a whole lot of benefit. And in this one trial, maybe even some worsening of negative symptoms compared to placebo, worsened cognitive functioning. And no studies that I could find have examined the impact of kind of medical cannabis or smoked, products on psychosis outcomes. So I think there is something here, particularly in regards to cannabidiol. But again, we need to study it more and in a more rigorous manner. So that would be kind of my conclusion right now. If my patient talked to me, I would certainly say there is not enough evidence with cannabidiol, and with THC. I would actually have a harm discussion, which I'll go into here in just the next couple of slides to keep rolling around. Finally, I kind of really want to bring this up. Dr. Hurd, Yasmin Hurd at Mount Sinai ICANN, she's really been the spearhead examining this line of research, right? Specifically cannabidiol at relatively high doses and opioid use disorders. So she's really seen this research from preclinical and neuroimaging stages to this initial human trial, where it's very interesting. What she did is that she had people with opioid use disorders who were in withdrawals. So they had not taken any opioids, and so now they were withdrawing, which can be one of the biggest triggers for recurrence of use, right? Withdrawals, kind of cravings, anxiety, cue-related cravings. She brought them into her lab and gave them cannabidiol compared to placebo and two different concentrations of cannabidiol. And what she found is that compared to placebo, cannabidiol significantly reduced cue-induced cravings and cue-induced anxiety. That's what this graph is showing. So on the left, we're looking at cue-induced cravings. Again, from everything we know about substance use disorders, cravings are some of the strongest reasons why people return to using illicit opioids, right? Cravings get overwhelming. So the higher the bar, the more, kind of the more the cravings. So when they were presented, they were presented sort of heroin associated cues compared to placebo, right? Cravings were significantly lower when they had received cannabidiol. And that effect persisted 24 hours after and even 3 days after that dosing of cannabidiol. And this right graph is looking at similar cue-induced anxiety. And similarly, we find that compared to placebo, which is the leftmost bar, we get less cue-induced anxiety with both 4 and 800 milligrams of cannabidiol sort of immediately after, administration, 1 day after, and 3 days later. So a little bit of nuance is indicated right here. What I would not want to tell my patient is that cannabidiol is a treatment for opioid use disorder. And interestingly, at least in New Mexico, medical cannabis, opioid use disorder is an indication for medical cannabis. So I have this discussion not infrequently with my patients. And I bring it up, right? And that's important for me to highlight because we have three highly effective FDA approved treatments for people with opioid use disorders that work, that at least two of them we know save lives, right? That reduce overdose mortalities, that reduce all cause mortalities. This is a much lower level of evidence. This is promising but preliminary data. So that's the conversation I'm going to have. So it's potentially would be dangerous, I think, for me to say, yes, cannabidiol helps opioid use disorder, and that's another treatment option. But I think there is potential here. For example, when I'm starting someone on methadone maintenance treatment, they might not get to a therapeutic dose for a week or two later. And during that time, they're having cravings, they're having anxieties, and they're often using other opioids. So could this become an adjunctive treatment to improve outcomes, to promote treatment retention and other outcomes? And Dr. Hurd is seeing this through, and that's what Dr. Katzman was referring to. We're going to be participating as a site in the next phase of the trial, which is funded by NIDA. But really all the credit to Dr. Hurd and her group for really seeing this through. So now with about, looks like 22, 23 minutes left, gonna go into some of the harm considerations for another 10 minutes or so before I go into a little bit into treatment. So few things right off note, should be no surprise to anyone. This is data, very recent data from the National Survey on Drug Use and Health. So, I often hear, especially from my adolescent patients, well, everyone's using drugs, right? Everyone's smoking cannabis, but not the case, and can be powerful to point this out with permission, that in fact, 75% of people in the US, right, 12 and older, did not use any illicit drugs in the past year. About 25% did. But when you look at them, look at this, cannabis is by far the most common. No surprise there. Because of access, because of public perceptions, variety of reasons, right? So cannabis is by far the most common illicit substance used in the United States. So the other thing that often comes up in my patients is, well, cannabis can't be addictive. It's a natural substance. Well, it certainly can be addictive. I have included the full DSM-5 criteria for our non-psychology colleagues here, right? Who may be in the audience. And these are really the criteria we look at that's here for reference. But in a very quick and dirty way, I do a lot of work with emergency department physicians, right? And they're busy and they're like, give me a quick way to know if someone has a substance use disorder or not. So as an addiction psychiatrist, I often turn to what we often call the C's of addiction, right? Because we all start with a C. It's a good mnemonic. And if someone has this as you're talking to them, chances are they have a substance use disorder. Chronicity. We know substance use disorders are chronic illnesses. We've known that since a groundbreaking paper by Dr. McClellan from University of Pennsylvania back in 2000 that really laid out a case for substance use disorders being chronic illnesses. I think if there's only one addictions paper, substance use paper anyone's going to read, that's the one I would read. Old paper, but really important waiver. Loss of control. My patients say this, right? I don't want to use, but I can't control it anymore. Use despite consequences. Substance use disorders have consequences, usually loss, loss of health, loss of relationships, loss of freedom, loss of life. And with many of these losses, people are unable to stop use. Compulsive nature. I can't tell you how many times people tell me something to the effect of, I wake up and it's like I have to take that drink or I have to put that needle in my arm or some version of it. And cravings, right? So if someone has this, they have substance use disorder. And according to Dr. Volkov, the NIDA director, from way back in 2004, there is no question marijuana can be addictive. That argument is over, right? And still I hear it from my patients 20 years later. The most important thing right now is to understand the vulnerability of young developing brains to these increased concentrations of cannabis. So how prevalent it is? There is some good studies of it. This review from 2020 showed that overall prevalence of cannabis use disorder was about 22% amongst recreational users. And how frequently used matters, with more frequent use correlating with higher proportion, higher prevalence of developing or having a cannabis use disorder. This very recent study from last year, looking at people using medicinal cannabis, right? Having those cards, the prevalence of cannabis use disorder there was about 25%. So interesting, right? When we see our patients with medical cannabis cards, doesn't mean we should not be looking into and screening for a cannabis use disorder. By far the most common, this is again according to the National Survey on Drug Use and Health, especially in the 18 to 25 age group, which is when we see a number of substance use disorders peak for a variety of reasons. And another very kind of hot off the press in the most recent version of JAMA Psychiatry, which just came out. These authors really looked at association between medical cannabis laws in states and rates of cannabis-related poisonings and cannabis use disorder. And what they found was that between 2011 and 2021, states that legalized medical cannabis saw about a 42 to 43% rise in diagnoses of cannabis use disorder, and actually about an 88.6% rise in cannabis-related poisonings. So again, things to be aware of, things to keep in mind, right? I'm gonna kind of move forward. The other big harm, and I think this is clear, in pregnant individuals, I am going to recommend them not using cannabis, right? The only clear association here is low birth weight. There was some indication in literature also of kind of a preterm delivery, but that association gets very weak when you control for other confounds, particularly tobacco use. But low birth weight is clearly something we see in human studies. And then in another kind of imaging studies, preclinical studies, you see evidence that cannabis can impact the neural migration, kind of an important process, right? Along with things like myelination, which is going to happen after birth, but to a greater extent, but important. And also, there's this interesting old study that showed that for people who are using cannabis and drinking alcohol, cannabis seems to like make the fetus more susceptible to the teratogenic effects of the alcohol. So with all of that, ACOG clearly says don't use cannabis during pregnancy, but still about 2 to 5% of pregnant individuals in the US use it. And when we look at patients I work with, right, low socioeconomic status, young, often with other substance use disorder, you can see that that number goes up dramatically, right? It's also excreted in breast milk because it's highly lipophilic. Again, something we should be avoiding. Next thing is kind of early use, right? Kind of use in adolescence, use as a child, associated with a number of adverse outcomes. And you can see here, including things like that have an impact, long-term education, employment, relationships, income. So lots of impact. So I think again, so one group where I'm clearly saying that discouraging uses during pregnancy or breastfeeding, the other big group becomes adolescents, young people, right? There was this old study showing a kind of a pretty dramatic loss of IQ points. I think that study was marred with confounds. But when it was repeated, there was an average decline of approximately 2 IQ points following exposure to cannabis in the use. There's also other kind of neurocognitive deficits found, but again, better quality studies are needed. There are questions as to what other confounds might be impacting. The other big piece I want to talk about in terms of harms, right? So we talked about early use, which will be a theme here as well as I talk about psychosis. This is something that I think the literature has really shifted. Maybe 5 years, 10 years ago, we were still going, well, we don't know what comes first. Is it cannabis or the psychosis that comes first? Is it self-medication? But I think the literature has really solidified around this idea that cannabis is a risk factor, right? It's not a causative, right? We can't say it's a cause, but it is a risk factor for schizophrenia and other psychotic illness. And I think it's fair to say, well, it's one of the few potentially modifiable risk factors in schizophrenia. And I'll show this in the next couple of slides. So most people who use cannabis don't develop a psychotic illness, right? There's a group, maybe about a third, that might have acute paranoia while intoxicated, but that goes away. But then there is a smaller group for whom that psychosis persists, right? So they're no longer intoxicated, but that paranoia is still there, or those perceptual disturbances are still there, and they get bothersome enough. We see them in our psychiatric emergency room or on our inpatient units. And that group, I think we need to start paying close attention to, because literature suggests that the cannabis-induced psychosis actually increases the risk of that person developing an actual psychotic disorder, right? In fact, and this might be surprising to many people, certainly was for me the first time I heard it, that out of all the substances, including methamphetamine, right, cannabis-induced psychosis, right, is the most likely to progress to schizophrenia. And this can happen in about a third of cases. And people who already have schizophrenia, who already have psychosis, if they use cannabis, especially high potency cannabis, they're likely to have a worse course and have more symptoms. And that's exactly what this slide is showing. These are people who got admitted to a psychiatric hospital for first episode psychosis. And it looks at over here on the left, and this is looking at positive symptoms. So things like paranoia, hallucinations, right? On the left are people who never use cannabis. And all the way on the right who are people who use daily cannabis of high potency. And you can see how those symptoms rise to where people who are daily using high potency cannabis had some of the strongest positive symptoms of schizophrenia. And this has been shown by other researchers as well, but I kind of really like this graphic, so I included it. Now, I mentioned one of the potentially modifiable risk factors of schizophrenia. So what evidence do I have? Am I just kind of saying it to be dramatic, right? Well, turns out quite a bit of research. A lot of this research is done by a European consortium of 11 sites that have really been tracking cannabis potencies and rates of schizophrenia, things like that. And this was kind of the initial classic paper. And they've published several things since then. But what this shows is this daily use of high potency cannabis is associated with a nearly 5-fold increased risk of developing a psychotic disorder. And that's exactly what this slide shows. So this is someone, and I want you to pay attention to this pink bar because those are the adjusted odds ratios. So someone who never used cannabis, that's the reference, their odds ratio of 0. And then the risk starts rising, right? When we get to that daily use of THC of over 10%, you can see that the risk of them developing an actual psychotic illness is about 5-fold higher. And this is data collected across multiple sites in Europe. And they also use this statistical modeling to claim that if high potency cannabis was no longer available, just about 12% of cases of first episode psychosis could be prevented. 12%. I think that is significant when we think about the impact of schizophrenia on our patients, on their families, on our communities, on the healthcare system. If we can prevent 12%, I don't think that's negligible. I think we need to pay attention to it. So I really want to point this out. The other thing I want to point out is look what's defined as high potency. over 10% THC. I don't know if who here has gone to a cannabis dispensary. I go at least twice a year with our fellows. We do a field trip to various dispensaries to see what's out there, etc. This is actually anything under 10% is a rarity. Most things I'm seeing are 20%, 25%, maybe 17, 18%, sometimes much higher with products like wax and glass shatter and things like that. So everything that I see in the market is high potency. So this is important. So what are some of the risk factors? Number of risk factors have been identified, a number of genetic polymorphisms, right? The most studied, I think, has been the COMT gene, but a number of other ones are also being looked at, along with gene environmental interplay, including childhood trauma, may be a risk factor. So when combined with one of these genes having a polymorphism, specific polymorphism, the risk of psychosis goes up. The three that really, as clinicians, we can control and talk about are potency of cannabis, the age of initiation, and how frequently someone is using. So to me, this really speaks to because most of my patients have no interest in stopping cannabis use completely. If I take that position, they're not going to talk to me. But even if I can work on harm reduction, right? Maybe they already initiated the use, but maybe I can drive them towards lower potency cannabis, right? Or reducing how much they're using, how frequently they're using. Potentially, I'm impacting longitudinal course. And yet, about 1.6 million individual or 1.2 million individuals in the US between the ages of 12 and 17 initiated cannabis use in the last year, in the year 2023, which is the last year we have full data for. So we have a long ways to go, right? And cannabis potency has been rising. So you can see that back in when I was in college, around 97 to 2001, the cannabis that was around was about 5% THC. And now the average potency is 16. And with my patients, I can tell you they're using far higher potency cannabis than this. So, good. We're right on time. Gonna go a little bit into treatment considerations, and then we'll leave time for questions and answers. So when we see our patients, the first point, I was actually joking about this with one of our senior psychiatry residents who's known me from when they were medical students. And we were talking about how one of the few times where I got annoyed, which I feel badly about, but this is disclosure, it did happen with residents or with trainees, was um, when we had someone had come in, they wanted to talk about, hey doc, can you sign my medical cannabis cards, for PTSD? And the student, the trainee said, no, because it's against our department policy. And there was, I think that we were kind of joking about this 2 days ago, that the resident said, I could see you got annoyed by that. And I thought about it, and I did get annoyed by that, right? Because when I say, or when any of us says something like it's against the department policy, what happens? That conversation is shut down, right? That patient is not gonna talk about it ever again with me. Maybe I don't agree about the medical cannabis, which is, usually the case for full disclosure. But I do want to involve the patient, deepen that rapport, and use that opportunity to offer more evidence-based treatments. That's the approach I want to take. One of our medical students years ago, Rachel Franklin, who then went on to do her residency at UCLA Harbor, did a project as a medical student where she evaluated communication patterns amongst medical cannabis patients, bud tenders, right? These are the people who are working at the dispensaries, and physicians. And what she found was that the communication pattern was basically entirely between the patient and the bud tenders. The physicians, the clinicals, providers were absent. We had bowed out. And I think when we do that, we're doing disservice to our patients. So that's kind of my one big take home. Involve the patient, talk to them with a non-judgmental, empathic attitude. Many of our patients have traumas, they have adversity, strengths. Recognize them, talk to them, get that thorough history. What do you use? Yeah, I use indica, but what's the strain? Do you have the box? Because that might tell us how much THC it has, how much cannabidiol it has, what else it has, right? How much do you use? How do you use it? Do you smoke flower? Do you vape? right? Vape flower or vape cartridges, all important things. If you get an eighth of flower, how long does that last? Why do you use it? Use those principles of motivational interview to elicit the patient's perspective. They are the experts on their lives. Why are you using it? Be open to learning from our patients. And then use that opportunity to deepen that dialogue, right? And I'm going to screen as I'm doing it. Some of the things I'm screening for are going to be cannabis use disorder, other substance use disorders, history of psychosis, along with the potential benefits to ultimately weigh that risk benefit discussion. So if someone does have cannabis use disorder, there are many effective psychosocial treatments. We know that contingency management works. It works for a number of substance use disorders, including for cannabis use disorder. So if that resource is available, use it. Some of the other well-established efficacious treatment approaches include family systems-based treatment, right? CBT, both individual and group. Motivational enhancement therapy can also be effective. And, even general drug counseling may be effective. So, there are things we can do. There is also a brief intervention that has been tried, especially for adolescents. Again, that critical period where we ideally want to intervene. So believe it or not, there is actually this 3-session brief intervention that's very motivational interviewing based. 2 sessions are mandatory with a third optional session with parents or caregivers. So I've included the structure of it for reference through one of the echoes that, I think Dr. Katzman, you and Dr. Joanna Katzman has really taken lead on and really spearheaded the adverse childhood experiences echo. Through that, we actually trained many New Mexico school districts in this brief intervention for cannabis. It works. Another really good intervention revolves around nicotine vaping. Studies show that adolescents that start vaping nicotine are about 4 times more likely to initiate cannabis use. So, can we go way upstream and intervene there to really start to minimize cannabis initiation and problematic use? Important thing to think about. Nothing FDA approved. This was my disclosure. Everything in the next 3 slides is off-label. So in adolescent, if I have an adolescent, I'm gonna maximize the psychotherapy. And if I'm gonna use pharmacotherapy, what I turn to first is N-acetylcysteine, which has been shown effective, especially when combined with contingency management, which we also offer at a dose of 1,200 milligrams twice a day, has been shown to reduce cannabis use amongst adolescents. Another one is topiramate, which has been shown effective in adolescents, but also tends to have a lot of side effects. And many kids, in my experience, just stop it because of side effects. But that's another one that's been studied in adolescents. But N-acetylcysteine probably is my go-to if I'm going to use a medication in an adolescent. For adults, again, nothing FDA approved, but several things have been tried. And I generally tend to use co-occurring illnesses. So if I have a patient with cannabis use disorder and alcohol use disorder, maybe I'm going to turn to naltrexone, which there is again some evidence for cannabis use disorder. Very little, but some evidence. If they also have tobacco use disorder, I might turn to varenicline, which again has some evidence in a randomized controlled trial, a pilot trial, that it might promote cannabis abstinence. There is some evidence with gabapentin, but I'm not, I think it's less strong and I'm not convinced, and I generally don't use it. There is also some studies of cannabis or cannabinoid-based treatments. Probably the strongest evidence comes from cannabidiol at higher doses, which does seem safe, but getting it can be a huge challenge because it's going to be very expensive at these doses. There's going to be no FDA-approved formulation that's going to be available. And then with commercially purchased products, there is also a lot of questions about how accurate are these doses, which can lead to problems. And if they're on other medications, cannabidiol also has many drug-drug interactions. So again, all of this takes a very patient-centered approach. I'm very excited about this. This study out of Columbia University, very recent, a couple of years ago, less than 2 years ago, they used a sort of a cannabinoid 1 blocker inhibitor to reduce the subjective effects of cannabis. And it did seem to be effective in reducing self-administration in early human trials. So I'm very excited to see where this study goes. And last slide, right on time, actually. for the last 20 minutes is this schema that comes from, actually, it was by Lochte a couple of years ago for people with cannabis use disorder. And I really like this approach where I'm gonna do, 2 to 4 sessions of motivational enhancement therapy and then get them plugged into cognitive behavioral therapy, relapse prevention protocol, right, which can be ongoing. And here at our clinic at UNM, I have the luxury of utilizing contingency management that one of our prior addiction psychiatry fellows actually got a grant for and implemented, and it's still running. Um, Terry Stanton. And so we're also going to add in contingency management, right? So that's going to be the major psychosocial approach. And then not always. Of course, I'm going to treat underlying psychiatric illnesses. But then if someone is saying, I do want to reduce, right? I'm doing motivational interviewing, they want to start reducing their use of cannabis, then I might start thinking about one of these medications, right? And one point or another, I think I have used actually all of them. But in general, I'm gonna use comorbidities to go with that. So I know I am at time. So that's a lot of information. I really hope this slide serve as a reference for you all. Thank you again. I'm gonna stop and turn it over to Dr. Katzman for questions. Thank you.
Oh my gosh, what a spectacular presentation. There's a question out there about how do we get the slides, and we will, um, with Dr. Bhatt's permission, send the slides out with the evaluation survey. Uh,
Absolutely. I wanted the slide shared, right? So yeah, totally.
Thank you. So much information there. It's just remarkable and so easy to understand as you speak. So thank you for a beautiful presentation. So there are questions around, lots of questions emerging, and encourage everybody to go ahead and keep putting questions in the chat, in the Q&A button. Can you say something about um, when you talk about uh, the risk for psychosis and then developing schizophrenia? Can you, in your experience, is that more treatment refractory? Um, that psychosis that we see as a result of marijuana, or is it kind of no different?
Yeah, so there is, thank you for that question. There is literature on it. And the clear association that seems to emerge, right? And these are again in people who are, admitted, right, for psychotic symptoms in a psychiatric unit and are concurrently using cannabis, right? So with that ongoing cannabis use, the clear association is that there are more positive symptoms, right? Doesn't seem to lead to more negative symptoms, but clearly the positive symptoms are greater. And also indication in the literature that that ongoing cannabis use is going to make treatment more difficult, where patients may not respond to it, their course of illness may be more deleterious. I think, and then again, there is a separate evidence that early initiation of cannabis, especially at high potency, especially more frequently, right, can increase the risk years down the line, like 10 years down the line, of actually developing schizophrenia. So that evidence is there. But what I don't think is there, at least from my understanding, is that having that remote history of cannabis use, does that make the schizophrenia that develops later in life more treatment refractory? I don't think we have that data, but with ongoing use, I think I would be comfortable saying that that makes cannabis more difficult to treat. Does that answer the question?
Yeah, yeah, yeah. One more question from me, and we have lots of questions rolling in. Snail, I remember taking boards, maybe one set of boards, maybe it was like 15 years ago or longer, with that very question that you put out there about which substance is the most likely to result in schizophrenia or a long-term psychosis. And so it seems we've known this for a long time. What, in your opinion, why has it been so slow that we've been getting that information out to the public?
I mean, I think, the reality is, right, that most people still who use cannabis don't develop a psychotic illness, right? So I think that colors that perception a lot more,
Mm,
right? where and especially when maybe there are therapeutic benefits and maybe people are deriving benefits from it. So, and then there's this public discourse where cannabis is seen as natural, right? Maybe harmless. So when you put all that together, maybe that risk gets downplayed. The second thing is that, right, even with the residents, if I ask them, what's the substance that's most likely to lead to the development of psychotic disorder? I usually hear methamphetamine, right?
Mhm.
And I think I've thought about this, and maybe it's because acutely that methamphetamine-induced psychosis is so prevalent, right? In that just during that acute intoxication and can be so challenging to manage, behaviorally or pharmacologically, that sort of gets embedded where maybe, people know others or maybe themselves have used cannabis, maybe didn't get psychotic, right? So it sort of colors and shades our perception. And maybe we don't want to believe it. Maybe that's the other part, right? Maybe we don't want to know that cannabis increases the risk of psychosis. And then we turn to those anecdotal reports largely as confirmation bias. I mean, this is all conjecture, but these are just some thoughts that come up for me, that we don't hear that much.
Great. There are questions here, various questions around parents' concerns about their kids using. How do they parent around that? If a child feels that they really need this for their social anxiety, um, how do you talk to parents about their kids using pot? You kind of alluded to that a little bit, but
Yeah,
I wonder if you could say some more.
yeah, I certainly can try. I mean, I think that's the probably the most effective, important intervention, right? I think to that, and it is, as we saw, so prevalent amongst our adolescents. I think there is data, right? I think we used to hear this with alcohol, kind of normalizing alcohol use in the home or in safe settings. But the data actually says that that's not a good thing to do, right? So maybe I'm starting with what not to do, right? And even with alcohol, what the data tells us is that we shouldn't be normalizing. We shouldn't be saying, well, drink at home when I'm here, we'll keep you safe. Just don't do it at school. So, I think similarly with cannabis, that's something I would recommend against when I talk to parents, right? And I think this is really about and there is like large cannabis youth data sets out of Canada. And some of the things they showed that really seem to improve outcomes and reduce cannabis use are things, for example, like having good role models. So maybe it's parents, right? Maybe it's siblings. And maybe for many of our kids that we work with, maybe that stable home environment isn't there, right? That nuclear family. Well, maybe it's grandparents or the extended community, mentors at school, right? So I think one of the things really becomes if I'm a parent, if I'm talking to a parent, really identifying the child's strengths and interests and seeing that can we get them connected, through some good mentorship, through activities where that interest is nurtured. Believe it or not, according to data, that reduces cannabis use in adolescents. Very clearly does. And that's not a medication, that's not psychotherapy. So parents have a good role to play. Not using at home sounds obvious, right? But is important. And then really interventions aren't that effective, right? Kind of that dramatic intervention. But what's more effective, I think there are some good books, right? And they're really written about adults, but maybe worth reading, and they're designed for evidence-based and designed for family members of people with substance use disorders. So one is called Beyond Addictions. I don't have any financial relationships, no kickbacks here. Another one is How to Get Your Loved One Sober. That's an older book, was written by some of our psychology faculty here at UNM. I think it's called Alternatives to Nagging, Pleading, and Threatening. And they use something called, community reinforcement approach, which is really about reinforcing positive or desired behaviors and basically not reinforcing the ones we don't want. And so I think that, so I think what I'm saying is that the parents can also benefit if they are able to either read those books to educate themselves or work with their healthcare providers to become more proficient in that. If those community reinforcement approaches available, because then they can bring that in to the adolescents. And I think the other big piece is what the ECHO is doing, right? Dr. Katzman, which is also training school-based health providers, teachers, nurses to again bring in the community. aspect. So probably could say a lot more, but I'll
Oh,
stop here.
fantastic. Can you say there's a question here about this idea of amotivational syndrome? What do we know about um, the reality of that?
It's a good question, and I don't. Maybe someone else here knows it, but I think last time I reviewed, I did not review the data on it here. Last time I reviewed on it, the data was kind of mixed at best, right? We do see again with especially with adolescent cannabis use, a number of outcomes. Outcomes sort of go down, right? Like worsened outcomes. Um, and I think amotivational syndrome might somehow fit into that. But the two caveats that consistently come across in literature, one is that there is a lot of confounds in that data, right? Other substance use, tobacco use, alcohol use, etc. And the second, even bigger one is how much of it is like residual effects versus like truly chronic persisting effects. So at what point does that start to kind of normalize or reverse? I mean, and I don't have a great answer to it. I will review it. It's a great question, but thank you. Maybe someone in the audience knows it, in which case I would be
If
uh,
somebody wants to put that in, I can read it. Um,
yeah, that would be great.
do
But
you,
my last reading was that the data is kind of mixed on that at best.
Great. 33 questions now in the chat. 9 minutes to go. So let's see what we can do here. The questions about the strain of cannabis and relation to
Yeah.
psychosis. And what do you
Yeah.
think about this? And there was a specific question about um, Delta 8 um, and its treatment for cannabis use disorder.
Yeah. Yeah, all excellent questions. So I think when it comes to the risk of psychosis, again, it seems like THC is really the driver, right? THC is the driver. The higher the potency of THC, the greater the risk, right? Cannabidiol may again play a modulating factor. There is quite a bit of preclinical data showing that cannabidiol may have a protective effect, right, on psychosis. I think again the human data is a lot more mixed, but there may be something there. So in general, and again, this comes up. In fact, it came up yesterday for me, and where was working with a patient I was supervising a resident in our dual diagnosis clinic, and it was a patient there really talking about alcohol use disorder. But as we were doing motivational interviewing, as we were speaking with the patient, the cannabis use started to come up. And the patient really, the resident was quite elegantly, actually, I was impressed, able to create ambivalence and really elicit the patient's perspective and have a rich conversation. And by the end of the session, what they negotiated is that the patient had been using a strain of cannabis that had over, I think, 20 to 25% THC. And, we kind of said, well, for the next 2 weeks, actually a CBT technique, right? Sort of a sobriety sampling, they call it. This is not exactly that, but something similar, where we kind of negotiated that for the next 2 weeks until we see the patient again, they will try 1-to-1 cannabidiol THC ratio cannabis, like 10 to 10%, 10% each. Um, so then the other question comes up where the patient asks, where do I find it? And this again, why I go back that we have to stay engaged, right? Like I know which dispensaries in town are carry some of these lower THC or higher cannabidiol or more mixed ratios. They're out there, they're rare, but they're there. And again, every so often with our fellows, we go around and talk to the dispensaries and just so we have a mental list so we can say, these are somewhere you may be able to find it. We'll follow up with her in 2 weeks and see what happens. She also has a history of psychosis pertinently, and that's part of the harm reduction. So THC is the driver. Delta 8 THC, not a lot of good literature on it, right? Where it fits into it. I know it's available everywhere. Like it's available in a store around the corner from my house, and my 7-year-old like points it out as Delta 8 THC. What is that? Right? And I'm sure the conversation will evolve as he grows older, but not a lot of data. So I would caution, especially with some of these newer kind of cannabinoids, often synthetically made, there may be harms that we don't know yet. So, for example, about a year or two ago, Normal, of all places, right? The cannabis advocacy group, NORML, Normal, put out an advisory, a public advisory, stating that a number of these novel cannabinoids, and I believe Delta H was included in that, may be associated with EVALI, the e-cigarette or vaping associated lung injury. I haven't seen it, but at least the concern is there, right? So again, we want to be careful with it. And that's the other piece that as we engage with the patient, I always tend to guide them towards this is the evidence, presenting it and coming up with a mutual decision. And hopefully we're guiding them towards things that are more evidence-based. So I'll stop there.
Yeah, great. Building on that kind of idea of potential wondering about lung disease, there's a question here about other physical harms.
Yeah. So yeah, I think, yeah, I highlighted the big ones. The ones I left out and I was mindful of it, but I left them out, is one is, of course, the cannabis hyperemesis syndrome, which has been garnering a lot more attention. I think our emergency department colleagues, if there are any here, probably can speak to it a lot more. I have certainly seen it. And it's this idea that with chronic cannabis use, especially higher potency use, people are developing this cyclical vomiting syndrome, right? And they wind up in the ER. And again, my approach to those patients, we do see them, usually adolescents. We've had several adolescents here who develop that and kind of working with them to start to work towards lower potency cannabis use. And I have them keep almost, and this is something I learned actually from Dr. Joanna Katzman, Dr. Jeff Katzman, right? Who had the headache diaries. So I have them keep like a vomiting diary, with sort of this education that as you start lowering, initially you might even see the vomiting go up, but let's see and track if it goes down, right? And kind of using that intervention, harm reduction to start to reduce you reduce that. And in my experience, as they do reduce their cannabis use, that seems to improve. But I think that's something that's worth bringing up. EVALI, that I just mentioned, the lung injury garnered a lot of attention back about 4 years ago, right? To where CDC and FDA had put out these advisories about otherwise young, healthy people winding up basically in lung failure, right? Respiratory failure after using vaping. And ultimately, at that point, the big culprit that they found was some of the vitamin E acetate that's contained in synthetic THC cartridges. So again, that's something I always deter my patients from using are those synthetic THC cartridges. And again, now there seems to be this indication that some of these other novel synthetic cannabinoids may also have a similar risk. So that's another big one that comes up for me. I think the data on cancer is unclear and mixed. Same with like overall lung function. There was this very interesting study in a prestigious journal, I think it was like the JAMA or the Lancet a few years ago, that showed that in people who smoke cannabis, infrequently or, not regularly, it doesn't seem to significantly impact lung functions. It kind of has this U-shaped curve where it may even be better in rare smokers, but then clearly as the smoking goes up, lung functions drop and it does cause harm to the lungs. So that's the other big one. Cancer data is mixed, but again, I do bring up, right? Combusted cannabis, lots and lots of combusted products. So from a harm reduction standpoint, important to minimize. I think those are the big ones really that come up for me. Sorry.
Richard Francis is right here. Superb, scholarly, wise talk. And has a question for you, Snehal. What about increased risk for bipolar disorder?
Thank you for bringing that up. And that's my mistake, my negligence that I left out a slide on that. So I appreciate you bringing that up. The association is a lot less clear, right? I think the clear association with a psychiatric illness worsening is psychosis. That's why I focused on that. With bipolar, there is less clear of a association, but in general, it does seem to worsen, kind of speed up the age of onset, along with like the frequency of cycling, with kind of more manic and hypomanic episodes as well. So in general, it seems to be associated with worsened course, but right, that question I think with that still comes up, and I don't have a definitive answer. Is it what comes first, chicken or the egg? But the association is there. Thank you.
Great. Last question that we can really get to here is there information that you point to that's helpful for youth, some kind of educational materials?
There is quite a bit, and one of the things I can do is, and we had actually done a whole session on it for the Echo maybe a year or two ago. So, Dr. Katzman, maybe later in the next day or so, I can send you some of the. Would that be okay, or to
Yeah,
you and your team, send some of those resources and materials that anyone interested can, I don't know, well, can get.
yeah, that'd be great.
Lots of resources.
All right, we're at the hour my friend. So good to spend the time with you, and you are an encyclopedia of knowledge. Thank you so much for
Thank
being
you.
with
I hope
us.
no one got bored. I hope people learned, and I hope, this was, yeah, useful. Thank you everyone for participating. Best wishes.
You are never boring, and we've enjoyed the time together and connected. And then when we disconnect, we all wind up in our own rooms back in our days. So thanks for the connection to you and to everybody else out there, and hope to see you in a couple of weeks.